Hi, everyone. Welcome. Thank you for joining AMETHIST Penn's February 2026 seminar. We're proud to offer this content through our AMETHIST Penn Hub, which stands for Achieving Maternal Empowerment and Transforming Health Through Implementation Science and Training. Funding for this hub comes from the NIH's Improve initiative, which aims to reduce maternal mortality and improve pregnancy, perinatal, and postpartum care across the country. As a reminder, we will be recording this discussion. It will be available on our YouTube channel for review after this session. Please feel free to put any questions in the chat throughout. We will also have a few minutes for additional questions after each presentation. So this month, we're very fortunate to have three presenters from across the Improve Network here to speak with us. Our three presenters are the recipients of the AMETHIST Penn 2024 to 2025 pilot grants. Joining us today are Dr. Kelly Zafman from the University of Pennsylvania with the Amethyst Hub, Dr. Jessica Olson at the Medical College of Wisconsin with the Ascend team, and Dr. Anna Newton-Levinson at Emory University with the Coral team. We're very fortunate to have you all with us today. We're excited to hear all about the work you've been doing with these pilot grants, and we're going to start with Dr. Zafman, so I will turn it over to you.
Thank you so much. And thank you so much for the opportunity to present our work. So my project title is the hardest part of my presentation to say, a mixed methods approach developing multi-level targeted strategies for de-implementation of routine antidepressant discontinuation in pregnancy. A mouthful. Go to the next slide, and thank you to Amethyst for supporting this project. No relevant disclosures. Next slide. So it's not surprising to most to hear that the United States is in the midst of a maternal mental health crisis, with 1 in 5 patients coming into pregnancy with a pre-existing mental health condition. Next. Untreated and undertreated mental health disorders increase the risk of many adverse maternal and neonatal outcomes, including preeclampsia, preterm birth, growth restriction, and are linked to long-term adverse neurodevelopmental outcomes for children. Next. And most importantly, untreated mental health disorders are a significant contributor to maternal deaths. Suicide is a leading cause of maternal mortality in the United States and across the world. Strategies to improve maternal mental health are desperately needed as a critical approach to reducing maternal mortality. Next. So, though no medications are without risks, the risks of untreated mental health disorders significantly outweigh the theoretical risks in pregnancy. All major OBGYN societies, including the American College of Obstetricians and Gynecologists, support medication use in pregnancy. And here is a statement by ACOG. Next. Yet despite the clear guidance from ACOG, more than half of patients discontinue antidepressants prior to pregnancy. This data comes from our co-author, Sarah Cornfield. Using Medicaid data from 2007 to 2009, she found that, more than half of medication discontinuation happens in the first trimester, and there are also significant differences by race, with Black and Hispanic patients more likely to stop medications during pregnancy compared to white patients. Next. In order to address this problem of the routine discontinuation of antidepressants in pregnancy, we developed 3 specific aims. First, to describe contemporary rates of antidepressant discontinuation during pregnancy and factors associated with continuing or discontinuing medications. 2, to assess determinants of antidepressant discontinuation during pregnancy from multi-level perspectives, utilizing a combination of implementation science and health equity in a mixed methods approach. And aim 3, the future goal of utilizing this information to inform future de-implementation strategies. And so for this study, my focus is on the first 2 aims. So first, I'll start with aim 1, and of note, this data is going to be presented at the Society for Maternal Fetal Medicine next week, so you all get a sneak peek, and I ask you not to share this data. So to fulfill the first aim, we partnered with a state-based private insurance database, Independence Blue Cross in Pennsylvania, and designed a cross-sectional study. We chose this approach as the database is linked to pharmacy claims data, allowing us to actually measure patient prescription fills, a better marker of medication use than prescriptions alone. We included patients who delivered from January 1st to 2023 to December 31st, 2024, with a diagnosis of depression or anxiety prior to pregnancy and had an active SSRI or SNRI prescription prior to pregnancy, which we defined as 3 months of consistent fill before pregnancy. Our goal was to examine rates of medication discontinuation, patterns in discontinuation, and outcomes, including differences in behavioral health emergencies between those who continued or discontinued antidepressants. Next. So from 2023 to 2024, about 29,000 members had a documented delivery event in the database. About 4,000 or 13.7% had a pre-existing diagnosis of depression or anxiety, which is just under the reported national average. And of these patients, just over a third entered pregnancy with an active SSRI or SNRI. Next. We then examined how this group of patients actually took their medications in pregnancy. 260 or 18% had no fills in pregnancy. 64.6% had a greater than 60-day gap in pregnancy. And click, this left only 17.6% continuing their medications uninterrupted throughout the pregnancy. Next. We compared demographics between patients who continued and discontinued antidepressants. There were no differences in maternal age or prenatal care initiation. There were a difference in the mean number of prenatal visits, although not clinically significant between groups. And unfortunately, the numbers were too small to meaningfully compare differences in race or education. Next. We also examined the rates of medication discontinuation by provider specialty. Here we have the top SSRI and SNRI prescribers for patients during pregnancy. Click, and you can see that those patients that had a prescription by an OBGYN had the lowest rate of medication discontinuation compared to others. Click. We also examined the timing of medication discontinuation, which is important to think about in terms of timing and intervention to prevent discontinuation. Click. The highest rate of discontinuation was in the first trimester. About 45% of patients had no medication fills or a gap greater than 60 days in that first part of pregnancy. Click. We then were interested in the rates of mental health emergencies between patients who continued and discontinued antidepressants. And so on the x-axis, we have the months relative to pregnancy, with 0 being estimated conception. The y-axis here is the ER visits for a behavioral health indication per 1,000 members. The blue line is patients who continued medications, and the orange line is patients who discontinued. And you can clearly see that in the first month of pregnancy, which is highlighted by the blue shadow here, there was a significant increase in the number of emergency visits for a behavioral health indication among patients who stopped their antidepressants. Click. And this is most significant in month 2. Click. And then in month 9, which represents the late 3rd trimester or early postpartum period. And these 2 time periods are also the times that have the greatest drop off in medication use in pregnancy. Click. Now that we had a sense of the data using large database data, we proceeded to AIM-2, and our goal was to use a mixed methods approach utilizing an implementation science and equity framework to understand why discontinuation happens and how it can be prevented at the level of clinicians and patients. So we first started with the study on clinicians. We recruited clinicians from 2 Penn hospitals and included OBGYNs, advanced practice providers, primary care providers, and psychiatrists. We chose these clinicians given that discontinuation happens early in pregnancy, and we also saw that rates of discontinuation were higher among non-OBGYNs. A survey was sent via email, which included the acceptability of intervention measure, a 4-item scale designed to assess the acceptability of antidepressant use in pregnancy. We then planned a semi-structured interview, which was guided by the survey. Clinicians were proposively sampled by specialty and by their AIM score, and we designed the intervention guide using CFER and health equity frameworks. Click. And here's a sample of the interview guide. You can see that the questions are mapped to CFER domains. So here are some preliminary results. 147 clinicians responded to the survey with representation from all specialties. There was overall a high AIM score, meaning that there was a high acceptability of antidepressant use in pregnancy, but we did see that internal medicine clinicians had a significantly lower mean AIM score compared to other clinicians. Barriers and facilitators were then elicited from the provider interviews. And here are some examples. Facilitators included antidepressant efficacy and safety in pregnancy, risks of medication discontinuation, prioritization of maternal mental health. And barriers included discomfort in providing counseling, lack of training on this topic, provider perceptions that patients had preconceived beliefs, and time constraints. We also examined clinicians' perceptions of equity in this space. Clinicians were not surprised that patients of color were less likely to continue antidepressants in pregnancy compared to white patients. Clinicians felt that this deserved attention, but did not feel that they had the right tools or resources to serve patients of color. And I wanted to highlight some representative quotes here. It is like violence to underrecognize and undertreat the suffering of Black patients during pregnancy. And it is not fair that they are being screened and their mental health issues are not being readily identified and then treated. My sense is that patients who are Black or African American suffer this type of health inequity in many, many different types of care. Here are a few suggested interventions that came out of these interviews, and I'll focus on just a few. Click. Scripted counseling for clinicians and standardized education materials for patients, and policies to reduce restrictions on psychotropic medications by nurse midwives. This was an interesting one that I discovered through interviews. Nurse midwives currently can only prescribe 30 tabs of SSRIs or SNRIs at a time, which is a restriction only placed on psychotropic medications and narcotics in Pennsylvania. And this was something that I didn't discover until my interviews with clinicians. And then here are some proposals to reduce disparities in this space involving BIPOC patients to develop interventions, which I'll discuss next, standardized screening referrals and treatment pathways, racially concordant care, and compilation of accessible resources that are specific for different cultural and minority groups. And finally, in tandem, we designed a mixed method study of patients. Patients were included if they were within 8 weeks postpartum and if they had a diagnosis of depression or anxiety prior to pregnancy and had an active SSRI or SNRI prior to pregnancy. The survey was sent to patients via patient portal. Individual interviews were planned. Patients were proposively sampled by race and whether they continued or discontinued their medications in pregnancy to get a breadth of perspectives. And again, we developed the interview guide with CFR and health equity frameworks. Next. And here's a sample of questions from the patient interview guide. Questions are again mapped to the implementation science frameworks. So 107 patients have completed the survey, and about half of patients continued their medications uninterrupted. The other half stopped either prior to or during pregnancy. This is a much higher rate of continuation that we saw compared to the insurance database, suggesting that there was probably some bias in patients that opted to complete the study. At this point, all patients, 15 out of 15, have completed the semi-structured interview, and that's where I'm sort of out of my project, and I'm planning to analyze that data next. So in terms of next steps, like I mentioned, I'm presenting some of this data at SMFM next week. I'm refining the qualitative analysis of the clinician interview, and I'm currently working on analyzing patient data, including the quantitative survey and the qualitative interview from the patient side of the project. And ultimately, my goal is to hopefully proceed to AIM-3 to use all of this data to develop multi-level targeted strategies to prevent the routine discontinuation of antidepressants in pregnancy. And my references are next. And then I'd like to conclude by thanking my mentors at Penn, especially Dr. Ham and the rest of my mentorship team, the Penn AMETHIST team for providing me a pilot grant award to support this work, and the Penn Pregnancy and Perinatal Research Center for all of my support. Thank you.
Thank you so much, Kelly. That was wonderful. I want to open the floor. We have 3 minutes if anyone has any questions about the work. what was presented, future directions, the implementation science pieces, anything like that. Feel free to put it in the chat or come off of mute.
I have a question. Good afternoon. I heard you say that they've seen there were patients that went into the hospital for some type of behavioral health issue within the first trimester. So how do they go about, I'll cut my camera on, sorry. How do they go about addressing that acute behavioral episode in the hospital, in the emergency unit? Like, so do they start them back on antidepressants, or do they use something, more acutely to address the issue? So what's kind of like the standard of care once they do come in?
Thank you so much. That's a really good question. Part of the sort of challenge with this data is that it's all, database. So I don't have kind of, unfortunately, the individual, patient experience, because I've also gotten questions about like, what are the emergencies that patients are coming in for? I'm sure that a small proportion of them are patients who either have a suicide attempt or suicidal ideation. And of course, those patients require emergency treatment, psychiatry consultation, and really require really intensive treatment. I do probably imagine that the majority of these, hopefully, aren't patients who are having such acute needs, but probably are having, symptoms of really poorly controlled depression or anxiety, difficulty with eating, difficulty with sleeping, concentration, the things that we think about are really debilitating symptoms of uncontrolled mental health disorders. It's a good question, like what happens next for those patients. We look to see what proportion of patients who had an interruption in treatment or stopped treatment restarted their antidepressant. And it looked like it was about 30% or so ultimately restarted their medication either during pregnancy or postpartum. And we're working on teasing out, what proportion was in the pregnancy and what was after the pregnancy. But I think it's one of the tough things is that, we don't necessarily have the data for these people. And I wish that we could see the trajectory. And I think it would be interesting to have more sort of patient level data to be able to look at for this.
Got you. Well, wonderful study. It was very interesting. So thank you for your contributions.
Thank you. I appreciate it.
You're welcome.
All right, we have time for just one more quick question. If you want to come off mute and ask your question, and then we will scoot to Dr. Olson's presentation.
I appreciate your presentation, but I came a bit late. But it caught my attention when you mentioned about midwives and drug prescription, if that was right. Okay, can you explain that to me, please?
Yeah, absolutely. So when a non-midwife prescribes antidepressants, in general, there's no restriction on the number of, pills that they're able to prescribe at a time. In the state of Pennsylvania, there is a law that's very specific that says that a nurse midwife can only, number one, prescribe psychotropic medications, including antidepressants, under the sort of consultation of a physician. And that's really quite different and specific for antidepressants because there are many other drugs, one could imagine more dangerous drugs, that don't require a physician consultation for a midwife. And the other layer of kind of sort of barrier in that law is that they can only prescribe 30 tabs at a time. Presumably, it's trying to, create some sort of safety mechanism for these. But the only other drugs that have the same level of restriction is narcotics. And of course, there are many medications that are much more dangerous than antidepressants that don't have this level of restriction. And so if someone is being cared for by a nurse midwife, a nurse midwife in Pennsylvania has prescriptive authority. They're able to care for patients on their own. And so if you're a midwife in the community and don't have a, physician that you work with, this may be actually a really big barrier to patients continuing their antidepressant treatment in pregnancy. So I think it creates like an interesting advocacy opportunity to be able to remove that barrier for patients and clinicians.
Wonderful. Well, thank you
Thank
so
you.
much. Well, thank you. All right, we are going to hop to the next presentation. Thank you so much, Dr. Zafman.
Thank you.
Next up, we have Dr. Jessica Olson.
Thank you very much. Let me grab my slide. All right. We see them okay? All right. So the title of my talk is It Takes a Village, Integrating Implementation and Dissemination Science Approaches to Improve Equity in Birthing Teams. As a background, Black women in Wisconsin are nearly 8 times more likely to die from pregnancy-related causes than Hispanic white women, and 5 times more likely than non-Hispanic white women. Community-based doulas reduce cesarean deliveries, use of pain medication, labor time, preterm birth, and postpartum depression. A key part of the Ascend Wisconsin U54 grant is to build community-based partnership. Let me restart here. The Ascend Wisconsin grant has 4 components. One of the components is the Bundle Initiative, which builds equitable partnerships between community-based doulas and clinically based healthcare workers. We created a vignette, which I'll show in my next slide, to show that equitable partnerships between clinicians and community-based doulas are possible. And then we use secondary data from Ascend Wisconsin to work on this proposal. So prior to applying for this grant, we were so excited to receive the U54. We were talking to people about the work that we were doing. And as we talked across our communities, academically and community settings, we noticed that there was skepticism in response to us saying that we intend to build these equitable partnerships between community-based doulas and clinicians. There was a general good luck with that, wide eyes, people going, you're going to try to do what? And as we met that skepticism, what we found ourselves doing, what I found myself doing, was actually talking about the 2 women who are pictured here. Dr. Anna Polotnik, our contact PI, the lead PI for Ascend Wisconsin, and doula Whitney Bingham, who is one of the most talented doulas in Wisconsin. These 2 women, as people were expressing skepticism, we're already building an equitable partnership. And so we thought, rather than continuing to tell stories verbally about their relationship, why not point a camera at them and just show people what it actually looks like when 2 women from different birth work-based professions respect each other, honor each other's wisdom, like each other. Would it help them believe these things are possible? Would it help them reach out and collaborate? So we shot a video. This video was a wonderful experience to shoot. What was really funny is neither of these women came in like ready to be, ready with the camera in front of them. They were both kind of, hesitant and holding back. And so while we were doing light checks and sound checks and things, they just started talking like they do normally. And most of the video is just them talking like they always do. We actually kind of went back and asked a couple of our interview questions, but the video itself that we shot was the 2 of them respecting each other the way they do in their day-to-day work anyways. We released this to a couple of different audiences across the Medical College of Wisconsin, not all of which are familiar with community-based doulas, and the overall response was, "This is great, but what's a doula?" So what they saw were 2 women getting along, but they weren't sure why we were doing this. We also found across perinatal professional populations that people weren't exactly sure what a doula was, and that prompted us to apply for this proposal. We were so excited to be awarded, and what we wanted to do, this is our team that works on the U54. What we wanted to do was we wanted to pilot implementation science strategies to review existing Ascend Wisconsin data and identify perceived stress points, needs, and opportunities to build equitable relationships between community-based doulas and healthcare providers. We wanted to pilot dissemination science strategies to determine if vignettes would be an effective tool across diverse audiences to address issues in maternal health equity. And we wanted to use CFER to describe facilitators and barriers for implementation and dissemination processes, outcomes, and strategies. From this initial team, we branched out into people who actually know how to shoot really great video vignettes, know how to work in media. So this is the all-star team that we were able to assemble, some of which are based in the Ascend Wisconsin team and others who are based elsewhere. Gerard Blanks and Maureen Post, as well as Camille Johnson and Xavier Johnson, are individuals individuals who work locally in the Milwaukee area to produce beautiful media. And then Juan Pablo Garland and Camila Vallejo are from the Eviction Lab out at Princeton. And we wanted kind of mentors to guide us in producing great content that would resonate across audiences. So we were so happy to use this pilot award to expand our team of just knowledgeable individuals and folks who could bring depth and beauty to the story we were trying to tell. We worked with this team. We met twice a month and wanted to start with the secondary data that was a requirement of the proposal. We had to have something from the original U54. And what we had was from AIM-1 of the Bundle Initiative. There were focus groups and interviews with 19 clinicians and nurses and 11 community-based doulas. That was meant to actually, the paper is shown here from Dr. Quinn and the rest of Dr. Polotnik's team, to outline implementation barriers to incorporating a community-based doula program to improve birth outcomes. This data was incredibly rich. It was not collected in order to identify stress points, but there was a lot of that kind of data within that we did a secondary analysis. We applied a rapid deductive CFER approach to ask, what do clinical perinatal professionals think about community-based doulas? And so here's an example of one of the quotes that came out of those interviews. The nurse that was quoted here says, "We've had doulas with very strong opinions about different things, and that interferes with our care and things that nurses need to get done on the bedside. I've had experiences with doulas where I need to turn a patient for heart tone reasons. My heart tones aren't looking great, and I need to turn a patient quickly. And the doula interrupts and says, we can do X, Y, or Z, or we need to hold off. And it's like, well, no, we have to do it quickly because the baby's in distress." And then moving on, the nurse also says, "This is not all doulas, but I feel like some doulas are very opinionated on like low birth interventions. I feel like it puts the patient in a tough spot when you have a doula as your bedside provider, but then you have a medical provider that's also offering an opinion." So we went through all of these transcripts and we pulled things like that. And then we went over them as a team. And we did find a lot of positive perceptions. We found things about acknowledging emotional support, navigating the healthcare system. There was actually a lot of support for doulas to be more active in postpartum care, which is not always a role of a community-based doula. But the healthcare providers really leaned into, wouldn't it be great if our patient had more postpartum care? That's something that they worry about with their patient population a lot. But a lot of acknowledgement about how they are advocates, how they assist with pain management, how they fill gaps in time constraints. So a lot of positivity in here that we want to acknowledge. However, there were things that we also categorize as more negative. So no understanding of the doula's role, concerned about the variance in certification, training, and quality of care, not being sure how they're specifically supporting patients, not sure how to interact with them. A perceived adversarial role was present in these transcripts, being concerned with their ability to integrate them in the clinical workflow. And then a few quotes that were very humanizing for the doulas on our team that said, some things that doulas don't, or community-based birth workers don't seem to understand, is that I'm responsible for everything that happens in that room. So, they are taking responsibility for whatever the doula might do. And if they don't know each other and they don't know what the doula might suggest, it is a thing that clinical healthcare providers express some nervousness about. So we had these lists of quotes that we went over as a team and concluded that this was an effective way for community-based doulas to outline what this vignette should include. Our team decided that the vignette should be by community-based doulas, led by them, made for providers, and explain their role and hopes for partnership, in hopes that that would be a useful tool for collaboration. So here's some photos from our beautiful day of shooting. We wanted to pilot dissemination science strategies. We wanted to determine if these vignettes would be an effective tool across diverse audiences to address issues in maternal health equity. We had a beautiful location to shoot on. This is our Thrive on King building that is part of the Medical College of Wisconsin's campus in the heart of the north side of Milwaukee. We had an opportunity to actually screen our vignette at a venue called the Black Birth Symposium, which is the largest maternal health gathering in Wisconsin. And at the Black Birth Symposium, what we wanted to do before we showed the vignette to clinically based healthcare providers was we wanted to have a panel for birth workers who were invested in improving Black maternal health and just ask if we got it right. Did we honor your voice? So when we got the surveys back, we got 72 responses back that largely said that the video completely, mostly, a few said somewhat, honored the voices of both community-based doulas and their clients. Feeling confident that we had honored, we went a little more in depth here, but we really just wanted to know, did we get it right? Did we honor your voice? We asked what the video did well. Many said that it showed emotional and practical support that doulas provided, really got some of the goals of the video, that they added some things about what we could improve. What was great was over half the respondents said they'd be interested in partnering with us in the future, sharing the video with their network, co-hosting conversations. So we're starting to grow our network of people who want to champion partnerships across community and clinical settings. Then feeling confident that we'd honored voices, we sent this to clinicians. We got 21 clinicians to do both the pre and post survey. And sorry, I should say clinical healthcare workers. I have the list of the breakdown of the professions on the next slide. But we had 21 participants working across different fields. A little more than half had worked with community-based doulas in the past. We used the interprofessional collaboration survey to look at changes in willingness to collaborate pre and post vignette. And we did see significant changes in the total willingness to collaborate, in improving communication and improving accommodations from clinical healthcare professionals to community-based doulas. And our professionals included OBGYNs, anesthesiologists, behavioral health professionals, and case managers. Their workload needed to directly clinically support individuals during the perinatal period in order to participate. So we did submit this to Implementation Science Communications as a manuscript, fingers crossed, for an accepted proposal, but we concluded that a vignette by community-based doulas for providers that explained their role and hopes for partnership did improve their willingness to collaborate. We did an after-action review with our team, and we wanted to look at barriers, facilitators, as we try to expand this approach. When we looked at our reach, we really saw the most opportunity for improvement. We really didn't reach as many clinicians as we'd hoped, so we want to target future recruitment with direct asks, reminders, possible incentives in future budgets. And we are going to put this on our website, so hopefully the reach will improve when we just make it readily available for folks. We do believe that we successfully scored and ranked themes that resonated with the audience that we identified. That was evidenced by the positive responses during the Black Birth Symposium, and we do believe that the message resonated with audiences given the positive response on the interprofessional collaboration survey. So we feel like the approach is feasible, has the potential for reach, and can be conducted equitably to improve collaboration between clinically and community-based birth workers. We want to give a wonderful shout out to the Ascend Wisconsin team and those who joined the team to be part of the vignette. We want to acknowledge the amazing folks at Amethyst who continue to answer all of our questions, and boy, do we have a lot of them. But we are so grateful to be supported in this space. We had so much fun shooting this video. We look forward to doing more. So grateful for the opportunity to train and learn and grow with everybody on this team, and happy to answer any questions. Thank you again for having me.
Another wonderful presentation. Thank you so much. It's such exciting work. So we love to hear about it. We did get a question in the chat from Dr. Gladney. Is there a standardized training for doulas in Wisconsin through the state's Department of Health or another reputable entity?
Yeah, so we actually have a few. There isn't a standardized, one size fits all. We do have the DONA training that is pretty commonly known nationwide. The doulas who are on the Ascend Wisconsin U54 are trained by the Health Connect 1 training model. That is a model that we implemented during COVID, and actually our state health department had to reduce or cease, I forget, services during COVID-19. So myself and my co-PI in the community partnership component applied for state funds to bring the Health Connect 1 training to Wisconsin. So not standardized, but we're actually really interested in looking across training models so we can, see improvement in outcomes, help people select the best model for them. We currently use the Health Connect 1 training.
Thank you, and great presentation.
Thank you. Thank you for your question.
You're welcome.
I have a question.
Yeah,
Great presentation, by the way.
thank you.
So I'm curious about the emphasis on community-based doulas. So how do you balance like honoring or partnering with like lived experience doulas, like certified doulas, should I say?
The question is, I'm sorry, so I want to make sure that I answer the question properly. How do we balance lived experience doulas instead of community-based? I want to make sure I understand what you're asking.
Correct. So I guess what I'm saying is partnering with community-based doulas versus certified doulas. How did you come up with, doing community-based rather than the certified trained, doulas?
So our community-based doulas are certified doulas.
Okay.
Yeah, so they are certified using that Health Connect One model. So I wanted to pause. I'm like, I think we're saying the same thing. The reason that we worked with the community-based doulas, and that is their phrasing, so there might be
Mhm.
a little bit of difference in how we're defining. Whenever I write doulas on something, our doulas will look at it and go, community-based doula, not clinically. So that is their phrasing that they want to be sure to be referred to as.
Okay.
But the ones who work on the bundle initiative are trained using the Health Connect One model and fully certified as full spectrum doulas.
Okay. Thank you.
Gotta be careful asking about the doulas because I love them so much. I will talk about them like all day long. They
Yeah.
are phenomenal women. All women currently.
Wonderful. Well, thank you so much, Dr. Olson.
Thank you again for having me.
Of course, we're so happy to have you. And we will transition to our third presentation, Dr. Newton-Levinson.
Great. Let me just share my screen. Okay, hopefully you can all see that. Thank you so much for having me today. I'm Anna Newton-Levinson. I'm an assistant professor in the Department of GYN and OB at the Emory School of Medicine with the Coral Research Center. And I'm going to be presenting on an implementation assessment. The talk is titled Assessing the Implementation of a Pragmatic Randomized Controlled Trial to Address Unmet Needs for Postpartum Support and Barriers to Care, Implications for Health Equity and Scale-Up. It's also a mouthful. So this intervention, I'll give a little bit of background on this first before we get into the current study. Georgia, as we've talked about, there are just unacceptably high rates of maternal mortality across the U.S. Georgia is consistently ranked among states with the highest rates of maternal mortality. 60% of maternal deaths in Georgia occur to those insured by Medicaid at delivery. And the majority of deaths and occurrences of severe maternal morbidity also occur postpartum, a time which healthcare visits are often poorly attended and is often inaccessible due to structural barriers. In addition, the Georgia Maternal Mortality Review Committee recently concluded that 89% of deaths in Georgia are preventable and identified chronic health conditions including obesity and high blood pressure, delays in access, and fragmented care as key contributors. The committee also highlighted that it was critical to address factors associated with care coordination, including inadequate case management for chronic conditions and pregnancy complications, as well as lack of social support and inconsistent screening for mental health issues. So to address these disparities, our research team developed an intervention to promote postpartum care attendance among individuals with cardiometabolic risk factors at Grady Memorial Hospital, which is a community-based safety net hospital where the SMM rate is more than 5 times the national average, and 38% of patients have a hypertensive disorder of pregnancy. So the team developed a pragmatic randomized control trial to use education and care navigation throughout the prenatal period to encourage postpartum care visit attendance. The trial enrolled 320 pregnant patients with cardiometabolic risk factors. This could be diagnosis with chronic hypertension, a hypertensive disorder of pregnancy, chronic or gestational diabetes, or preconception obesity with a BMI of over 30. And patients were enrolled at 20 to 34 weeks gestation, enrolled in prenatal care, and half were randomized to the intervention and half received standard care. And the main outcome of interest for this intervention was attendance and receipt of a comprehensive postpartum visit. So the intervention involved three major components that were informed by ACOG standards of care, from a community advisory board feedback, as well as qualitative interviews with Grady patients. And I'll note my positionality in the study. While I contributed to the formative work, I did not directly have a hand in designing this intervention, but have come in to help facilitate the implementation assessment. And so this intervention included three major components, the first of which was an education and care planning component. Patients received 20 modules related to a variety of content about taking care of themselves during pregnancy and preparing for postpartum. And this was intended to be delivered via up to 8 visits, with 4 additional visits as needed, in sort of 25 to 45-minute sessions in between their OB appointments. And then there was a design that it would be adaptive throughout the pregnancy, of kind of checking in on patients, seeing what their needs were, and tailoring kind of the educational modules to those needs. The other component was that patients and the navigator would then design a plan of care, planning for their postpartum period. So they'd identify screening needs during prenatal care, identify what follow-up care they might need in their postpartum period, come up with a contraceptive plan, come up with a plan for breastfeeding, as well as introduce them to who their care team was. And this plan would then be integrated into the Epic EMR system for their provider to be able to review at their postpartum appointment. And the final component involved care navigation and social service navigation, as well as provision of resources. And so based on needs identified through educational sessions, the navigators would provide direct referrals or warm handoffs to organizations, care reminders, scheduling assistance, as well as baby supplies. They'd have a visit during their delivery hospitalization, and have a check-in with them 1 week postpartum. So an implementation assessment wasn't originally planned as part of the original intervention, but through kind of discussion with the team as the intervention was rolling out, really we thought it would be important to understand what the barriers and facilitators were to implementing the intervention in order to really inform the scale of future versions. So the implementation assessment that I'll discuss today integrated 2 implementation science frameworks, including Carroll's implementation fidelity framework, to assess implementation adherence and association with outcomes that we were already going to be looking at, as well as the Consolidated Framework for Implementation Research, or CFIR, to assess barriers and facilitators to implementation. And this study had 3 aims. We first sought to assess implementation fidelity and identify which components of the intervention were important for overall effectiveness. We also sought to describe what multi-level factors served as barriers or facilitators to the implementation of the intervention itself, and drew really on the CFIR framework for this, and assessing kind of how implementation was influenced by factors related to the design, the inner setting, the outer setting, and individuals within the organization. And then the third aim was to assess the extent to which individuals were equitably able to participate, as well as receive benefits from the intervention, as well as what were structural drivers that might have influenced intervention implementation. We used a mixed methods design. I think these are popular today in our presentations, drawing on qualitative data from multiple perspectives. So we interviewed patients, we interviewed clinicians who should have been involved in the intervention in reviewing postpartum care plans, as well as members of the implementation team. And we also drew on quantitative study data, check-in notes, educational module logs, referral logs, as well as patient surveys that were distributed 12 weeks after they delivered. And so we used CFIR and the Carroll frameworks in our interview guides to develop our questions, and use coding and thematic analysis with those. And we actually conducted a content analysis of REDCap data. We exported all of the data from the program logs and from all of the notes from our intervention, and conducted a content analysis as well as descriptive statistics and SAS, and have used a mixed methods analysis in triangulating all of this data together. So in our first aim, we sought to understand how implementation fidelity influenced intervention outcomes. And the main outcome of the study, postpartum visit attendance, actually did not differ significantly between the intervention and controls, which we were quite surprised by. However, when we looked deeper, we found that there was a dose response for the main outcome with the number of prenatal care study visits that they attended, so those education sessions. And so about a third of participants only had one education session, but we saw this dose response, particularly for multiparous patients, that the more education sessions they attended, the higher rate of postpartum visit attendance. And this was only significant, though, in comparison to the control group for the multiparous participants. So to dig a little bit deeper, we, through this assessment, found that implementation fidelity did vary. The initial intervention was envisioned to take place over up to 6 to 8 visits. And as you can see, nearly 40% of participants ended up with only one prenatal education and planning visit. And only a third of participants received 3 or more of these education and planning visits. And from our interviews, we identified that a major influence on the number of sessions participants received was the timing that when they were enrolled in the study. So some patients were enrolled later in pregnancy, closer to 30 weeks, and the team could often only conduct 1 or 2 educational visits before some patients delivered. And another very strong influence was that patients who were not able to show up regularly for their prenatal care appointments weren't then able to show up regularly for their education appointments. So we saw in our data that most patients initiated care in the first trimester, but a third did not. And others attended visits only sporadically, which was often associated with sociostructural stressors like housing instability. And so in these cases, the implementation team would often have to try to cram in the education into 1 or 2 sessions to make sure that they got, when the patient was there, that they were able to receive all of the information. We also found other variations in implementation fidelity were related to the intervention kind of being tailored to patient needs. So modules were selected or prioritized based on patient needs, and referrals and navigation were also then given based on those needs. So only a third of patients did not receive any referrals, and a third did not have significant care documentation or care navigation documented in their patient records. And so we would expect that, but again, there may have been some differences, and that we'll be digging into a little bit more in our next analysis of looking at for those who did have referrals and did have care navigation, did that significantly influence outcomes as well. So moving to AIM-2, we examined some influences on the implementation of the intervention itself. We found factors across CFR domains influence the implementation. In the inner setting, the Grady system and appointment structure often influence the ability to be able to work with patients. Staff were trying to catch patients between appointments, and sometimes patients had been waiting for long periods of time and didn't want to stick around any longer. There were also, I think, developing kind of trust with others who were in the clinic was a major barrier and facilitator throughout the study in terms of making sure that everyone knew what was happening with the intervention and what folks were doing. But I think a main thing also in terms of the patient impact was the development of trust between the navigator and the patients. And we heard time and time again that this was a really important component for successful delivery of the intervention and something that really made a difference to patients. There was also a really strong champion on the implementation team, and all of them were incredibly dedicated to the patients. And this was very much reflected in the interviews that we saw from patients themselves and how much it meant to them to have somebody who really they felt like cared about their well-being. There were also external kind of constraints from external resources and organizations that they were trying to refer patients to, and I'll talk about that in just a minute. And this quote just from the implementation team was related to appointments, and they said, they only have 20-minute appointments, and sometimes you can catch them between doctors, but then I feel like that impedes the workflow and of the nurses and the doctors, and so you really need a separate space with people delivering this intervention. And this study was more like you have to catch them between their appointments. And I just don't think that was the right way to do it because some topics can be sensitive. So some important kind of lessons and what can be improved next time. I want to just briefly mention, we also discovered that clinicians were largely unaware of the intervention but really felt like when they learned about it, that it would have been very helpful for them. So there was a care plan in EPIC that they were supposed to review, but almost all of the clinicians we spoke with actually didn't access the care plan during postpartum visit appointments. And while this might not have influenced attendance, it could have influenced the comprehensiveness of the visit. So in AIM-3, we sought to more deeply look at social and structural barriers in pregnancy. And we already saw that some structural barriers inhibited some participants from fully engaging in the intervention if they weren't able to show up for their visits as frequently. And participants in this intervention had numerous and often compounding social and structural challenges during pregnancy. Nearly a third of participants received a mental health referral. 20, almost a quarter received food insecurity referrals. About 20% had documented food access issues. Another 18% had challenges with their social context, either in terms of changes in social and structural stressors, lack of social support, or experiences of intimate partner violence. And participants also had housing concerns as well as kind of time affordability concerns. We did look at whether intervention participants had differential postpartum visit attendance by social structural stressors, and we didn't see this. We didn't measure it in the controls because we were doing these in-depth assessments with the intervention participants, so it could be that there may be a difference between intervention and control participants, but we weren't able to assess that. But within kind of the intervention participants, those who had higher social structural stressors did not have a significantly different rate of attendance. And that may actually be due to support. We did, however, also discover that in implementing the intervention, there were several significant challenges navigating connecting participants to social services. So there were, as I said, multiple and high needs for social structural support, but often there was an overwhelm at the organizations that the care navigators were trying to connect participants to. There was overburdened staff who may not be able to communicate well or follow through. Sometimes there was no shelter that had a room available for a patient. Mental health services were often difficult to get into, and some participants felt could be stigmatizing. And there were also significant wait times at other resources where the resource was closed. We had some challenges with the WIC office having strange opening times. And so I think this really conveys just, that we had people who were dedicated to trying to get people into these services. And if you didn't have someone working 4 hours with you trying to get you into care, what would have happened? And so I think just the ability to connect folks to care was really a powerful lesson from this study. And I'll just share one note that really summarized that, and that's this a progress note from one of the patients that says, patient continues to require navigation for multi-layered issues for housing, compliance with care, need for CHF, blood pressure, oxygen, et cetera. The social worker involved, there's a social worker involved. The participant states she receives no follow-up, and assistance only happens when she comes in for her study visits. The participant was able to obtain a hardship letter, but unable to obtain housing because all of them are full. So we learned that in terms of scale up, this intervention potentially could consider extending more into the postpartum period to continue to support those patients to come back to care. We heard from our interviews that a navigator rooted within the health system, but also who had community connections, could really navigate both of those worlds well. And overall, there would be a need to improve provider awareness of their care plans and Epic, have a dedicated private space and scheduling for education sessions. And then really, I think the biggest component is having formalized referral relationships and backup plans ready to go with community resources when you're trying to connect patients with those services. And I think there's some limitations and lessons learned from our study overall. We had some IRB challenges with understanding what an implementation assessment was that I wasn't expecting. And so kind of readying IRB for how what it means to add on an implementation assessment to a randomized controlled trial. Our data was set up for taking notes. It wasn't set up for analysis. And so that was another piece of kind of how we set up things to be able to get into looking at implementation. And then the implementation assessment occurred after the intervention concluded. So we may have had some issues with remembering or just being ready to respond to interview requests. And then I think there's some additional data that we're still waiting for outcomes that we're hoping to get soon. But our next steps are to complete analysis, to develop an implementation toolkit for navigation and intervention, education interventions, and hopefully our findings will inform the development of a group-based care and navigation-related intervention that will build on this in the future. And I just want to say thank you so much to the students who have helped me with coding and collecting this data, and to Amethyst, and to all of the mentors and mentoring we have received. Thanks so much.
Thank you so much. Another wonderful presentation. We have 2 questions in the chat, so I will go through them briefly. I think that's all we have time for. So the first was, what did you do to capture recent changes in social and structural stressors, and the lack of social support?
Yeah, so our navigators had some standardized questionnaires, and one of them was kind of, has there been a recent change in social structural stressors? And I think that really came from asking them about housing, food, social support. And so it was really intended to capture a very broad set of experiences, and to know if through their pregnancy they had this kind of recent change, and to be aware and ready to support them. Social support, we coded based on program notes. So if there was notes about, feeling like they didn't have anyone, having a difficult relationship with their baby's father or with their family. And so we coded that actually from the program notes. There wasn't a formal assessment.
Great. And then the second question that we had was, could you share the qualifications of the postpartum care attendees? Were they community health workers from the community? Did they continue to meet with them in the postpartum period?
Yeah, so they many of them had a nursing background or health education background. They were not employees of the health system. They were through this intervention, and I think that some of them knew the system really well and some of them didn't, and I think that yielded differences in being able to kind of navigate those. But they really, I think, already had ties in the community. They weren't community leaders or community health workers, though, so they didn't have as much of that relationship. And the thing about this intervention was really trying to impact postpartum attendance prenatally. And so I think one of the things was we did a 1-week call, and I don't think that was enough. I think that really the patients needed and continued wanting that support into their postpartum period.
Wonderful.
Thank you.
Great. Well, thank you so much to our presenters. Thank you so much for all of you attendees who joined us today to hear about the wonderful projects that have been going on through the Improve Network. Thank you again to Dr. Zafman, Dr. Newton-Levinson, Dr. Olson for joining us, for taking on these projects. We're happy to be here to continue to support you. So thank you all so much for joining, and we will see you next month.